Back for night 2 of the Heartland EMS for Children's virtual pediatric symposium focused on children with special healthcare needs. Before we move on to tonight's presentation, I just want to go over a few quick housekeeping items. First, all attendees are in listen-only mode. Your mics have been automatically muted and webcams disabled. Second, all attendees must watch for at least 120 minutes and complete an evaluation in order to receive your certificates. That evaluation will pop up tonight after the session, but will also be sent out in a separate email tomorrow for you to take. Please be patient and give your state coordinator a few days to get those certificates to you, as we're going to be going through these individually to make sure we meet our state-specific guidelines. If you have any questions or concerns, though, please go ahead and reach out to your state coordinator and we can help you troubleshoot. And finally, there's going to be a 30-minute Q&A panel session after the presentation. As you have questions, please make sure you're typing them into that Q&A box located at the bottom of your screen. We will get to as many of them as we can tonight, and we'll make sure to follow up on those that we don't have time to address. So finally, I'm excited to introduce tonight's wonderful speaker, Paul Sodders. Paul is a survivor of childhood cancer, a parent, and a tremendous advocate for children with special healthcare needs. He'll be sharing with us his years of experience so that we can learn from his story. Paul, welcome. I'm going to hand the evening over to you now.
Thank you so much, Brittany. It's so great to be with you all. This is a little different for me. Usually I am on a stage moving around in front of a few hundred people. I've taken a break since COVID of actually presenting, as you can imagine. So this is a little bit different for me, just staring into a computer screen and delivering a message. So I hope that I keep you engaged tonight. I've got a mixture of stories, I've got a mixture of videos, and some really good information to carry over from what happened last night to this night. In short, we want to give you some good tools tonight, and it's just an honor to be here speaking to school nurses, physicians, EMS folks. You have been on the front line. I will tell you, always on my mind as a healthcare provider and the parent of a child who's medically fragile in a group home. So it really is my honor to share my story and share some thoughts with you all today. So I want to start out, right? I think first of all, I've got a great background. I've been in healthcare for a long, long time. I have a unique perspective as a former pediatric patient and now the father of a medically fragile child. So in addition to hearing how you can make a difference in your community tonight, I really want to share my family story with you, who I am as a person, why I'm passionate about teaching folks some good tips and tricks on how to deal with children who are medically fragile, especially when it comes to an emergency situation. No means am I an expert at all, but I think through my experiences, right, as a former patient and now a father, I've learned a thing or two along the way, just in networking with other parents who have families very similar to mine. So you're going to hear about my children. This slide is very, very appropriate for me. Love to talk about my kids, love to talk about myself, love to talk about teaching in healthcare. That's what I do. It's what's in my background. But also, Tomatoa here loves to talk about himself as well. And I thought this is fitting with my child, and you'll hear about Ty here in a minute. It's not uncommon for us to watch Moana 8 times a day because he loves repetition. He loves the repetition in music. So I thought this slide was very, very fitting. I'm also going to challenge your thinking today because I know we have participants from very small communities. I know we have participants from very large communities. And I know some of you will say, we can absolutely put in place what he's talking about tonight. And I know there are participants who are going to say, we can't do that. We're too large to do anything like that in my community, and perhaps vice versa. But what I'm going to challenge you to do is to think about how you can implement these strategies as you move forward from tonight's talk, and not think about how they're impossible, but think about how we can make them possible. Right? I'm an advocate. I love this quote. I try not to label past medically fragile children, because I think all kids are special. All kids have different needs. And so I think this quote was very fitting for what we're going to talk about tonight. I also want to talk a little bit about my prior life and following the definition, and you'll hear me talk about this a little bit tonight. For years, I was the spokesperson or one of the spokespersons for the Organ and Tissue Donation Agency in Iowa. And in my world back then, I had to be very careful with what I said, the words I used in the audience that I was talking to, whether it was in front of a television camera, on the radio, or to a group of donor family members. And I always hearken back to this old college professor I had who said, you know, choose your words wisely and follow the definitions of the words that you're going to be using. This will lead you on a trail of appropriateness for what you're saying. And she was pretty progressive back then, right? So this was mid to late 80s, and she really taught me a lot. And it got me thinking about a word that we even used in tonight's flyer, and that's the word atypical. So if you follow the definition of atypical, you know, through Webster's even, atypical equals abnormal, and abnormal equals undesirable, and undesirable equals unpleasant. And so when we're choosing our words, and I know we talked a little bit about this last night, when you just remember the phraseology that you use when you're discussing different populations of people, because none of us would ever want someone to call a loved one unpleasant, which in many of our minds, that's where we lead if we follow the definition. What I love is the word different, right? We're all different. Every child is different. Every adult is different. We all have different needs. We all have different desires. And so you'll hear me say this word a lot as well. There's a subset of our population that are medically fragile, but we're all different. And so I really, really like this word. We're also going to talk about this tonight, right? As we get to the root of how, when we go into these very scary situations, right? And it's okay to admit that you're scared when you're on an EMS run, or you're dealing with a child in an emergency room, or a child who's sick at school, that we have to learn to kind of train ourselves to pay attention to the things that we cannot see, and how do we get to the root of issues that aren't so obvious than the things that we can see. So tonight, my hope is that you take away these things. I hope that you learn about me and my family and other families similar to mine. I hope that you have some tools for your toolkit that you can walk away with tonight for that next EMS run when you're involved with a pediatric patient. We're going to talk about how you can engage your community. Something that I'm very passionate about is being prepared in advance, especially with medically fragile children, and what you can do as a provider to help prepare yourself and your colleagues before an emergency happens with a medically fragile child. So a little bit about me. As I said, I've spent over 25 years in healthcare. I've spent the past 7 years in healthcare benefits and technology. I was fortunate enough to be involved with the Department of Health and Human Services with the United States government and HRSA, traveling across the United States with organ and tissue donation and grant reviews. One big thing about me, of course, I'm a proud dad. I am a former foster dad. I am disabled myself. I am a leg amputee. I've spent many years in Park City, Utah, teaching disabled youth how to ski. One of the most fortunate things that I ever had, an opportunity to play professional wheelchair basketball with the Chicago Bulls back in 1991 when they were at their heyday. So just a few other things about me. I love the Chicago Bulls and the Chicago Cubs. And I am passionate about continuous learning and improvement. And so that's really why I got involved initially with the Iowa Department of Public Health, and then you all tonight. So there's another thing you need to know about me. I am a 13-year-old boy trapped in a 53-year-old body. I like to capitalize on myself and the things that I've been through as an amputee. You'll see these are shirts that I own. Unfortunately, that is not my tattoo. I would love to get that tattoo at some point. And then the snow angel that I found. I think one of the things that I've learned throughout my life, and 53 years old now, I was initially diagnosed with the issue that I'm going to talk about at 13 is my grandmother taught me at a very young age to choose joy with everything that I faced as a child, and then everything that I would initially or eventually face as an adult, that I had two choices. I could wallow in despair with the things that had happened to me, or I could find joy in what had happened to me with my experiences. And that's what I choose to do. One more picture. This is my favorite picture. It throws people off every year when I do it. This is my Throwback Thursday picture for Facebook. So everyone's like, what's with the two legs? I'm like, think about it. It's my Throwback Thursday picture. So just another thing I wanted to share. So I want to talk a little bit about myself and the history and really medicine in general, right? We've come a long way. Here we have some nurses smoking. And I remember the very first time I was admitted in a hospital, I had this direct line from my hospital bed into the nurses' lounge, and just thought it was funny. All day long, they were running in and out of there smoking as fast as they can, and then, running into patients' rooms. And so I had this great view of that back then in the late 70s, early 80s. And I used to just watch them smoke all day long. Back then we shared a room, right? I was in a room with 5 other pediatric patients, and we would fight over which of the 3 television stations that were available to us then that we would watch all day and all night. I was in the hospital for 6 days after my first biopsy as a 13-year-old, and I'll tell you about that in a minute, right? Things have changed. Here you'll see this old hospital receipt that I dug up. Back then in the hospital, we didn't have call buttons. I mean, we literally had dinner bells that we would ring for our nurse the first time I was in the hospital. After my biopsy, I was on crutches for 2 weeks. I was told, I couldn't bear weight. My first MRI in the early 80s was over 8 hours long. I had to lay on a table for 8 hours long when MRIs first came out. And so I've seen a lot then, and then navigating the new healthcare system or growing with the healthcare system as I became a healthcare provider myself, and then again, kind of on the parent side with my child. And then some things never change. Back in 1947, we were charging 8% interest on past due bills. So, very different back then. But then again, when it comes to money, I guess some things never change. So I want to tell you a little about me and my diagnosis. When I was 13, I had this passion and I really wanted to play basketball in school. And I knew that I had to have a physical before I could do that. So I went to have a physical. I had not noticed the lump that was on the top of my left foot, but my doctor sure did. Didn't like the feel of it at all. And so he sat my mom and I down and decided, we should have a biopsy. At the time they couldn't read the biopsy at my local hospital. So it was sent off to Mayo, and we found out that it was a desmoid tumor. And desmoid tumors are aggressive, fibrous tumors. They, you'll see there on the slide, pretty darn rare. Back then, it was even rare for a young man to have it in a foot, when these would typically show up in the abdomen in females, right? So they're usually attached to the connective tissues. It can invade surrounding tissues. So they were very concerned about my foot. They were very concerned about spread. Even though it wouldn't metastasize, it was just very aggressive and hard to get rid of. So I got shipped off to the Mayo Clinic to have this removed. Removal was successful. Again, right, early 80s, I had a tumor removed from my foot. I was in the hospital, I think 7 days. Nowadays, right, I mean, women are having babies and they're out the next day. And so our healthcare has changed that much. And it just has given me this perspective as I look back on my own experiences as a pediatric patient. The one thing that they weren't so concerned about with was the recurrence of the desmoid. The recurrence actually at that time was pretty low, 20 or 30% relatively. And so they just sent me home to watch it. So I had that first surgery to remove it. I had radiation following that. And then within 4 years, I had a recurrence in my thigh, or in my calf, excuse me. So back up to Mayo, back for another surgery, back for more radiation. Again, within 4 or 5 years, 3 years, I felt a lump in my knee, recurrence in my knee, more surgery, more radiation. And then I had a 5-year break. I made it to my early 20s. I graduated college. I was pretty successful in my career early on as a radiation therapist with Northwestern Memorial Hospital in Chicago. And I felt another lump in my thigh. When I had the MRI at that point, the tumor had actually grown and was a little bit more invasive and went clear up to my hip. So I had surgery to remove that. I had radiation again, and actually had preoperative radiation where they actually, during surgery, when they're opening up and they remove the tumor, they'll bring you down to the radiation machine and treat the tumor bed, and then they close you up. And I had a surgical complication after that. I had a post-surgical infection that was pretty severe. I ended up being in the hospital for over 3 months. And it was a rough time. I was very, very sick. My parents, again, I was living in Chicago. My parents were in Iowa. They were coming up constantly to support me. And in the end, what I decided to do was have an amputation of the leg. They had to do some nerve work when they were removing the tumor. I lost all feeling in my leg. I had this very aggressive infection that just ate away at a lot of the muscles. And so we thought, well, my only chance to be mobile really was to have an amputation. So I did do that. And I had a prosthetic. I was getting along great for a while. And then I joined the Chicago Bulls, the wheelchair team. And I was actually thrown from my wheelchair during a game and injured my amputation, and actually had to have a second amputation after that and some muscle damage. So from that point on, I was without a prosthetic and pretty much just mobile on crutches. I alluded to my career earlier, spent 10 years as a radiation therapist. Here's me in front of one of the old machines. Spent another 15 years in organ and tissue donation in Iowa and nationally for the Department of Health and Human Services. The last 7 years, I've actually been in health and benefits technology with a startup in Des Moines, Iowa that's been very, very successful and has given me great perspective and an avenue to talk to healthcare providers across the United States, as well as some of the biggest names, brand names that you have. We have Facebook, LinkedIn, Sephora, to name just a few, as some of our clients, and I've been able to work personally with a lot of these folks as we're doing health and benefits and wellness for them through special technology that we own. A little bit more about me. As you can tell, I believe in kindness. I believe that we can change the world. I believe that all of our kids are special and they all have different needs. So I find joy, again, in everything that I do. Again, my granny taught me that way back when I first got sick. I instilled that in my kids, and you'll meet my kids here in a second. These are my two pride and joys. Reese is on the left and Ty is on the right. I always tease Reese when I introduce him. Reese is a college student, Ty is an Olympian. So Reese is about to be 22. He is studying biomedical engineering at Iowa State University. He chose this career specifically because of his father and his brother. He has this hope and this aspiration, and you can tell I get a little emotional, that he wants to improve and enhance mobility devices for people that need them. So that is his goal in life, and it is something that he is very passionate about. He chose that path on his own. He is excelling at Iowa State University and will graduate next year. And I just couldn't be more proud of him. Ty is my 19-year-old. He's on the right. Gold medal Special Olympian. He was able to participate in bowling at the state level. And my kids are like any other kids, with the exception of Ty being medically fragile, right? They're wonderful. They're amazing. They can be the biggest jerks in the world, right? As any parent would know. They are full of love. They cause me worry, and they can be the kindest men that you've ever met. Part of Ty's story was actually told best by his brother, Reese. And this happened a few years ago when Reese was in high school. We got this call one day from one of Reese's teachers saying, hey, we would love to share this video that Reese put together, and we want to share it with every school in the district. And specifically, we want to start using it in training for new special education associates that we're hiring on. I said, well, that's great, but I don't know what you're talking about. Reese had never shared with us that he had put this video together, right? And it was for a class, and he was to make a video presentation. It could be about him, it could be about his family, it could be about anything that he was passionate about. And he put this video together, and I'm going to share it with you now. I think it best describes both of my sons, really. Even though this was done years ago, this gives you a glimpse into who each one of these young men are.
Today, I would like to introduce you to my brother Ty. Ty has severe cerebral palsy, and this condition makes him physically and mentally handicapped. This means that he is confined to a wheelchair and learns at a slower pace than most people. Ty is 12 years old and in 6th grade at Ames Middle School. Growing up, I often had to care for Ty and babysit him. This can be hard a lot of the time because when Ty can't communicate with us, he gets really frustrated. So commonly, my job at home is to keep Ty happy. By singing to him, getting him what he wants, and even just talking to him. I love my brother because even though he lives within all these confinements, he still finds joy in seeing other people have fun. And still laughs and smiles almost all the time. Some of his optimism is probably from his mischievous sense of humor though. Like it's cool sometimes. If he doesn't want to do something, he'll pretend to be asleep by half closing his eyes and giggling at everyone around him. He also, when driving his electric wheelchair, will go into a random classroom and start laughing because he knows he isn't supposed to be there. Or sometimes he'll just crash into the door. He loves school so much because he has a lot of great friends and teachers who do a lot of one-on-one stuff with him. Ty gets a lot of great opportunities through school. Like just the other week, he competed in the Special Olympics for bowling. Ty not only has taught me care, responsibility, time management, and how to pay attention to others' needs, but how to always find the silver lining and stay optimistic. I have talked to some of Ty's friends when we went to elementary school together, and all of them think that Ty's awesome and funny. Many of them say they even look up to him, as do I.
So pretty special kids, right? They have been just so amazing and a joy, and I love to talk about both of them, really. Another interesting story about Reese that we had to kind of switch our thinking early on. I think we had always just gone about our daily life, right? He grew up with a dad who was an amputee on crutches and didn't see anything different in that. And we were going to one of his kindergarten open houses one night, and we went as a family, and of course, you know, he's excited to show us his room, and other kids are there, and we're talking with other parents, and out of the corner of my eye, I see him in one corner actually getting mad at one of the kids. and he left the situation, you know, pretty much like we had taught him. So I was proud of that. And he came over and I said, buddy, what's going on? And he said, Devin kept asking me what was wrong with you. And I said, well, what did you say? And he said, I told him there was nothing wrong with you. I said, what's wrong with you, Devin? You know, he didn't understand why Devin was asking. And I think, you know, it was at that point we realized as parents that we had explained to him why I was different, why people might stare, why people might ask them these questions about me. And really, indeed, his brother in a wheelchair as he was growing up, because we'd never had those conversations with them. And to him, it was normal, right? I was just dad and Ty was just Ty. And so we had to prep him for those conversations. And I thought to myself, you know, how wonderful would it be that we would never have to prep a child to have those conversations and intelligently speak about what had happened to me and what was wrong with his brother to other children. But we decided to take that educational approach, right? We thought, you know, we can be a conduit, he can be a conduit to have other people learn about medically fragile people and just people who are different from ourselves. So this is my 19-year-old. He, believe it or not, is smiling after having double hip surgery. This was the next day. A little bit about Ty. Ty was born 8 weeks early. He was a relatively healthy premature baby until we started to feed by mouth. We slowly started to introduce him to eating by mouth. And when he ate, he would suffer these horrible apnea and bradycardia spells. This is all within the NICU, right? We knew we were going to be in the NICU for a while. They were so severe, though, sometimes when we were trying to feed him that we would either have to bag him, and then there were a few occasions where we had to do some chest compressions. So very, very scary time for us. In the meantime, while he was in the NICU, you know, I tried to continue to work as much as I could for the Iowa Donor Network. I was thankful that at the time my wife actually worked for a hospital in Ames, Iowa. We were able to finally move Ty closer to home so she could work until he got out of the NICU and go see him and do the feedings and everything. And he was probably around 4 or 5 weeks old at the point. So, right, still well before his due date. And I got this call at work and I could barely make out what my wife was saying. And the only thing I could really hear was, you have to come now. So I started the drive from Des Moines to Ames. I got there, and when I arrived, Ty was not in the NICU. And indeed, my wife was in the CT scanner with him. They had rushed him down there. Unfortunately, when one of the NICU nurses was removing him from his bassinet, the cords got wrapped around kind of one of the edges, and she dropped him, in a sense, just lost her grip on my baby and dropped him to the floor. And so all these emergency protocols, you know, here's this poor kid who has came early and fought to breathe the first part of his life and then fought to eat. And then we have this accident happen, and it was just one of the most horrific moments as a parent when you're making all this progress and something like this happens. Now, the good news was that, you know, he was swaddled and had this very thick hat on, and nothing had happened to him. And thankfully, what they believe is because he had all of these leads on him, and even when he fell, that actually slowed down part of him being dropped. But this poor kid has gone through, at this point, you know, more than most of us go through in a lifetime. And so I think it's important to kind of see where he started out and also kind of his progression through life. So this is him. We're so fortunate that we live in Iowa. We begin in-home therapy here right away as soon as kids are diagnosed as being medically fragile. So Ty started school at 3. He doesn't have to leave school until he's 21. Within a week of him being diagnosed, we had in-home therapists coming in. We had speech and occupational therapy and physical therapy coming in. So very, very fortunate to have this support network in Iowa to get him off on the best foot possible, right? We also had a little hiccup here. One of the first physical therapists that we had that came into our home, and mind you, here's a baby, 6 months old, starting to receive these therapies. The physical therapist looked at us and said, well, he'll never be able to do this, and he'll never be able to do that, and he'll never be able to, walk, and all of these things. And we had made a conscious decision at parents, it's time to ask for another therapist. Again, with everything that I had been through in my life as a pediatric patient, and now the father, right, of a patient, I wanted to surround him with positivity and really joy, and have a therapist who would focus on the things that he could do and may be able to do, and not focus on the things that she never believed that he would be able to do, because I thought that would hinder his therapy. So we made that change. We made that change for my son. I think we made the right call. I think we would do what any parent would do to advocate for their children and give them the best care that they could have. But that's really how we started out. So he's classified as being triplegic. He has very, very, very limited use of his right hand. He's very rigid. You can almost mold his hands, if you will, because of his spasticity. He's very limited verbally. And not being able to express himself, this is another life lesson for us. We learned early on, he started to have behavior issues and self-harming issues out of frustration from not being able to express himself. So when he would become frustrated, he would not only try to harm himself, but he would try to harm a caregiver, his parents, his brother. He would hair pull. He would get such a grip on our clothing that sometimes you literally had to rip a shirt off to get away so he wouldn't injure you. He would bite, he would scratch, he would do all of these things. So all of these things that we had to learn as a parent to navigate now, and really to warn others with this sweet, sweet boy who is so full of joy, would get so frustrated that he would act out in that way. So a couple things about Ty's journey. I told you what happened early on. He has also had a complete spinal fusion. He has had multiple tendon lengthenings in both of his groins and legs for surgery. Initially, early on, his hips didn't grow right, so he had bilateral femoral osteotomies. And then just within the past few years, his hips started to fail again. So we made the very difficult decision to do bilateral femoral ostectomies. So we had them remove the head of the femur. So he has the floppy leg syndrome. We go in for Botox appointments, right? Hands, arms, legs, groin, and rotating, because there's only so much Botox you can get at a time, just to give him some relief with the spasticity. We've also had phenol injections too to help with that and the pain that he feels in his legs. He has a baclofen pump that is implanted into his belly that gives him intrathecal medicine into his spine to help with the spasticity as well. He's also had a surgery to have that replaced, because those only last so long. And then out of all of this, the only normal thing the kid has probably had was, we had tubes put in his ears when he was a young kid. So he's been through a lot. He has taught us so much as parents. He has taught us how to navigate the system in Iowa when it comes to special needs care and medically fragile children. He's helped us navigate the medical community more than we would ever thought we would need to, being both of us being in the medical community. So even though Ty can't feed himself, use the toilet, complete normal self-cares, we decided early on that we were going to give him as much as an opportunity as any other child could get. We found a place called, getting a little bit of feedback, sorry. Found a place called Camp Courageous in Iowa that has adaptive adventures. You can see him ziplining here and enjoying a train ride as well. We feel so fortunate that we have these opportunities for these camps and to give him the opportunity to do things that he's able to do, and not because he's disabled, but just limited because of his abilities and able to do some of these things that he loves so much. I also want to tell you a little story that we encountered and just how far we've come as a society. Even though I think we have a long way to go, right, in general, we've come very, very far. When Ty was about 6 or 7, we had decided to take the family out for pizza one night. Just, let's load them up. Let's go out to dinner. And I remember very distinctly, we were sitting at a table and my wife was feeding Ty and Reese was telling us about his day in school, and we were eating and just enjoying family time when this older couple came up to our table as they were preparing to leave the restaurant. And they started by apologizing for interrupting our dinner. We're so sorry. We just wanted to come over and say hello. And we said, well, hello. And then they began to tell us how proud they were that we had actually brought our wheelchair-bound child out to a restaurant. And, my wife at the time and I looked at each other and, we were a little shocked because, he went where we went within reason, and you'll hear more about that later as well. But then they continued their story and had let us know that about 60 years ago, they gave birth to this, beautiful little girl, and they realized early on that something was wrong. And she was eventually diagnosed with CP. And they started to receive this immense amount of pressure from their parents and their grandparents telling them that they had to institutionalize their daughter, that they would never be able to take care of her. They had no idea what that was going to be like, and that they had to institutionalize her. It's just what you did. And the woman had tears in her eyes, and she said, we waited for about a year and we finally succumbed to this pressure, and we signed her over to state care. And she said, I regret that. I've regretted that every day of my life. I keep thinking back to, the support that we have now within the medical community and the services that we have now. And she just kept thinking, I could have probably done this. I could have probably done this. And we were really dumbstruck, right, of the difference between the generations. And on the way home, we were talking about how blessed we were to have that support, to have the medical community that we have, to have advanced EMS, to have the advanced services that we have now with therapy coming into our home and helping us out and being able to put Ty in school early. All of these interventions have really allowed us to keep our child at home as long as we did. I mentioned earlier that we made a pretty difficult decision just about a month ago after waiting for an opening for 2 years to put him in a group home. As you can imagine, for me, he was getting bigger, getting harder for me to move and transfer from a wheelchair to bed and vice versa. And so we made that decision, but I keep thinking, I had 19 and a half years of him living here. And really at this point, most of our children are fleeing the nest by now anyway. So he is thriving in this group home. He's actually kicked us out and told me bye-bye a few times. Doesn't want me spending extended time in his house. And why would he, right? He has a staff of young females and young men who wait on him hand and foot and take care of him and take him places, and he's just having the best time there. Real quickly, this is just a quick funny story too. He can be a little ornery, like I said. Every kid can be jerks. Ty is very verbally limited. I said that. One night I was sitting next to him and he kept saying hug, hug. And usually when everything's firing right upstairs, we get out a very clear word. And I thought, oh my goodness, he wants a hug. I'm going to capture this. I need to capture this and get a selfie. I went in for the hug, and you can see the look on his face. As soon as I went in for the hug, he went to grab my glasses. He wanted my glasses. And so that's my look afterwards. But he's just a normal kid. In there, he is just a normal kid. He understands what you're saying to him. Even though he can't always express it. So a little bit more about just having a medically fragile kid at home for me that I think is important to know before you're interacting with parents at all in any situation is that with Ty, my experience has been, it was like having a newborn for 19 and a half years. The sleeping schedule was off. We often slept when he slept. We couldn't get that rhythm of sleep going for him ever really consistently. And so it was a crapshoot every night on whether or not we would get a full night's sleep or if we were going to be up trying to comfort him. We ate when he ate. We tried to give him these fatty foods that we needed to give him because he was skinny and he needed the calories. And so we just were really on his schedule. We made huge sacrifices as a family. I'll talk about some of his sensitivities a little bit later on, but Ty is hypersensitive to loud noises and crowds. And so there weren't a lot of places that we could go as a family that you would typically do with your children. And so early on, we had made the decision to make sure that we were doing those special things with Reese, and we would take turns as parents doing that. Ty would never tolerate a water park because of the sounds and the noise. Ty would never tolerate a place like Disney World. Ty never tolerated fireworks. Ty never tolerated parades or sirens or the bright lights. So those are all things that we had to be very careful about wherever we went and whatever we did. And usually we were split as a family. And so one of us would go with Reese so he could have those normal childhood experiences, and one of us would stay home. And that's not to say that we didn't travel. If we were going somewhere for more than a night to sleep overnight, we absolutely brought Ty with us. We took trips on airplanes. We went to Cozumel with the boys, nice relaxing vacations where we could know we were going to be in a quiet place or a relatively quiet place and then just enjoy each other's time. But the normal things I think that we look forward to doing with our kids, we always had to be very careful because he was just so hypersensitive to certain things. But we still wanted to give those experiences to Reese. So there's one more thing that I want to say about my son that you have to know, and that is that when you look at him and he's in his wheelchair, he is obviously physically disabled. And when you look at him in his wheelchair and the way he interacts when we're not around, you can tell that he has cognitive issues. And we have noticed that outside of our circle has caused people to treat and talk to him in a different way. And one thing that you need to know about my son is that he hears every word that we say. And he understands every word that you say to him. He just can't express it back. I also worry about my son because in a medical situation, an emergency situation, especially if it involved me as a father and I was immobilized, if Ty was laying down, you would never know that he had a rod in his back. You would never know that he has both hips missing. You would never know some of these things that are going on internally. And so that's why it's been very important for us for emergency preparedness. And we're going to talk about that more on why we have done the things that we have done in my home and now his group home to ensure that if there's ever an emergency, we're prepared for that and we can better prepare any EMS provider that is taking care of him. So we're going to talk about what can we do as a community, right? How can we make a difference? How can we learn together? And I'm really passionate about this, and I became passionate about helping healthcare workers change their views and thinking when it comes to our friends that are medically fragile, right? And this happened really after an interaction with one of the ER physicians that we had during one of our many trips to the emergency room with Ty over the years. One of his issues early on was that he battled with severe reflux, and we would have these vomiting episodes that were so severe that he would get a GI bleed. He would start bleeding and then he would start vomiting blood. So over a course of a long time, probably every 1 to 2 months, we were in the emergency room. We had him on every medication we could think of to keep this down. His spine started to curve more. His tone was not where it should be, and he just battled this very, very severe reflux. And it was actually during one of these trips to the ER, we had a newer ER physician that had just started at the hospital. We had never seen him before. And of course, and we used to say it too when I worked in the hospital, we were a frequent flyer. We were in there a lot, right? Like everybody knew us in the ER. Everybody knew when we were coming in. Everybody knew what he needed. It was all pretty much down on starting the treatment course. And this new ER physician came in and he says to me as the nurses are taking the vitals and my wife is telling him what's going on, says to me, "So tell me about your son." So I thought, okay, newbie, right? I mean, can't you read a chart? So I go in and I start from the prematurity, right? My typical spiel about, this was prematurity. He was 8 weeks early, and giving him the whole thing. And he stopped me and he said, "Mr. Sodders, I've read all that. I'm familiar with your son's history and why he's here. I want you to tell me about your son. How can we keep him comfortable? What bothers him? What does he understand? What doesn't he understand? How can I keep him calm when I'm trying to examine him? Is there a certain thing that I need to be doing to make him comfortable?" And I thought to myself, my wife even stopped, that no one had ever asked us that. We were always talked to as parents during these situations. It was always, this is what we're going to do. And no one had ever thought past the medical treatment into, I need to examine him. What can I do to keep him the most comfortable? Because I understand he has his physical limitations and his cognitive limitations. And so that moment really stuck with us for a family for a very long time. We never just had anybody ask us about Ty and what he likes and what comforts him. So after really learning, and I mentioned this earlier, after learning what my good friend Vicki Peterson is doing at the Iowa Department of Public Health through this grant on bringing more tools and awareness on how to work with this medically fragile population, I knew I had to get involved. I knew that we could talk about and teach better ways and have people be more prepared to not just deal with the medically fragile children, but all children really in emergency situations, right? We've woefully been unprepared in the past, and it's scary. I'm telling you, as a person who was a radiation therapist, primarily children with cancer, every new child with cancer that walked through that door scared the shit out of me every time, because I didn't know what to expect. Every child was different. Every cancer was different. Every diagnosis was different. So I get it. I get how scary that can be, and I get how unprepared we can be and how we can provide more tools and training to make this even a little bit less scary. And I have this pipe dream, right? I have this pipe dream that the tool that we're developing at, not just the Iowa Department of Public Health, but the tools that you all have in your states to have families be better prepared. So I can hand a binder over to the EMS worker who is coming into my home. I can go to a website like Smart 911 or another website that I'll show you later that counties are actually developing that are medically fragile registries, if you will. So EMS can tap into these very important issues and learn about these children before they ever walk foot in our house. I'm that passionate about it. I think we can make make a big difference. And I invite you all on this journey with me as we make a difference for our kids. So I'm gonna play a quick video. I mentioned this in the beginning. You'll see some videos throughout the presentation. We'll take a couple of polls. I think it's important, right? I really tried to choose some educational videos that were outside of the Heartland, so you could see what other EMS providers and other EMS groups are doing. This one is about treating kids versus adults, and right, we all know that it's very different to treat adults from children, but when you overlay the complexities of being a medically fragile child, what we're talking about and what we're going to learn about over the next hour or so becomes even more critical.
A lot of people ask, how is it different taking care of a child on a call as opposed to adult? Is a child just a little adult? And the answer there is no. Their systems are different. Assessing them as a patient is different. Vital signs are different. Treatments are different.
Whereas you or I would start having our pulse rate go up, we'd start complaining about not feeling well. Same scenario with the kid, they're fine, they're boom, 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 and then all of a sudden they drop. And when they drop precipitously.
How do you get a history? How do you get what's going on out of an 18-month-old who can't talk, who can't describe symptoms? You have to use parents, use diagnostic tools, use your exam, other things that you can see on the outside to try and figure out what's going on with them.
10% of the total patient load that you see in a year will probably be between the ages of birth and maybe 13, 14 years old. And then 10% of those will be what we consider to be sick or critical kids. So for some people, you might be talking 0 to 1 critical kid a year.
We know those are what we call low frequency, high risk patients. We don't see them very often just because kids generally aren't as sick as adults are.
One of the problems with pediatrics is that it's really not something that we deal with a lot. Consequently, we have to continually train and practice on it.
You really should be capitalizing on practicing those skills that you do very, very infrequently, that when you do have to do them, makes a huge difference.
What do I think when I go on a call for a kid? Is it everybody's going to be a little more hyped up? Everybody's going to be a little more nervous? I think in general everybody feels a little bit more for a kid.
I've been doing it for 30 years and still would not say I'm proficient.
Probably the biggest thing that's really making a sweeping change in healthcare is medication errors and what we call a culture of safety. Almost all the interventions that we do for pediatrics are weight-based. So it's math in a very chaotic situation. We don't randomly pull up medication or calculate things in your head. We always look it up.
There are tools out there that allow EMS providers to make more rapid decisions in terms of medications, dosages, and those kinds of things.
You're using different meds and concentrations that you're not really used to, so everybody's a little nervous, and you've got to deal with the parents, and so the dynamic's very different.
Probably the other largest difference between treating pediatrics and adults is the necessity to involve the family in the decision-making process in what we call family-centered care. Their primary source of patient history and information, and being able to rely on that information when the patients aren't able to speak on their own behalf. And they obviously know their children better than anybody else on the planet.
To see these beautiful little people when they're young and be able to keep them healthy and give them a good start to life, I mean, I think that's one of the highest callings that you can have in medicine. I don't think it gets better than that.
So a few years back, I had a pediatric person, a 6-year-old little girl, whose brother was helping her do tricks on her bicycle. So she was standing on the seat, holding onto the handlebars, riding. She fell off and fractured her trachea. So her windpipe was essentially crushed. I know for a fact that without our intervention that day, she wouldn't have made it. We made a huge difference that day. We were able to keep Mom calm. The whole call went pretty well, and she came back 2 weeks later and visited us at the station. Mom was happy. She was happy. So that's what makes it all worthwhile. You get a couple of those in 27 years, and you're okay.
So being prepared, right? That's what we're going to talk about in the next hour. Obviously, I think, some of our bigger EMS centers and bigger cities are so prepared and trained. I'm worried about our smaller communities if they have the resources and the equipment and really the training, right? We want to make sure that even though that incidence is low, for runs, it can happen, and will you be ready? So we're going to talk about how do we identify strategies, right, that can help us to find the real issue when our kids are medically fragile. I told you my story. There are so many other stories out there in every community that are the same but different. And you heard this stat last night, right? 20% of our kids are deemed medically fragile by HRSA. And they're saying these are kids, right, that are at increased risk for chronic physical, developmental, and behavioral, and sometimes even emotional issues. So how do we prepare? How do we best serve these kids really before an emergency even happens, and sometimes during that emergency? I mean, these kids are kids that can have breathing issues, they can have communication issues, chronic pain, learning, as we said, behavior, mobility issues, all of these things. So we're going to talk about all of this. What are some of the considerations with some of the diagnoses in kids that we see? What can I look for? Or what can I think about when I'm entering a home with a medically fragile kid? And then how can we be proactive in our community before the emergency even happens? One more quick video before we take a break. I just want to share this with you. This is a video that I share with families like mine. I've sent this link out more times than I can count. Because I want people to know, I think some of us get a little bit too comfortable relying on the system. relying on our social worker, relying on EMS, relying on our pediatricians, relying on the ER, that they're always going to be there. And I think we need to take a part in that, in being prepared as families as well when we have a medically fragile child. So even though this comes from Texas, and you'll hear the little twang that they talk about, I think it is an incredible video for families that have medically fragile children should watch. Happy to send this link out. I'll give my contact information out at the end. So I'm happy to send anything out that people want, but I invite you to take a listen to this for a few moments.
Here in Texas, we go through all kinds of emergencies. We go through all kinds of disasters, everything from tornadoes to hurricanes to snowstorms, ice storms, wildland fires, a variety of things that can impact us as citizens of the state of Texas. The big question is, are you prepared?
It is extremely important for families who have kids with disabilities or special health care needs to be prepared for a large-scale emergency, because we're the most vulnerable families.
One of the most important things that you can do is reach out to your local fire department, EMS, law enforcement, local health department, emergency management divisions in the city and the county that you live in. And the reason that's important is because they can identify where you live, what your needs are prior to an event happening.
We've always believed it was very important that you become familiar with the people that are the first responders, because they're liable to interact with your children at some point.
I would highly encourage you, if you've never had the opportunity to network or meet with your local fire department or local EMS, go spend some time at the station, invite them over to your house. You know, as a firefighter, if I had a resident in my district that we knew that they had special needs, we made it a point that we put it in the computer system. So when we got dispatched to that address, it prompted us that we had that information. So we knew going to that residence, we already had a plan in place of what we were going to do to be effective in managing that situation.
So it may be helpful for each family to sit down and write down the different disasters that could happen. And maybe it's not a hurricane or a tornado. Maybe it's losing electricity. Maybe it's losing water. What do you need to have in case that happens?
Having a go kit is important. It needs to be something that you can have to sustain at least 2 to 3 days with the family members that you have. When you hear the word go kit, people think of some type of bag or some type of kit that's ready to go, and I want to make it simple for you. The easiest thing to do is to use a bucket. You know, buckets are multi-purpose. So an easy rule of thumb is for every 2 people you're going to need a bucket, and you need to have all the supplies in that bucket to sustain a minimum of 3 days. Those items are going to include food, they're going to include daily amenities, they're going to include life safety devices, fire, light, tools, those types of things that will allow you to sustain for that 3-day period. One of the most important things to have in your survival kit or your ready-go kit is documents. This is just a print off of the documents that are needed, and it's in a sheet protector. But driver's license is important to identify you. A passport, if you have a passport, social security card, contact numbers and addresses. Right now we have everything programmed on our phone, but when we can't access our phones, we need to know how to get in touch with family members. Your medical information, your family members' medical information, your medical insurance, vehicle insurance, homeowners insurance, those are all great to have as well. Now that we've got this information out there for you and you already kind of have an idea of what you need to have to be prepared, I highly encourage you to start having a plan, know what you want to do, take advantage of the warnings, take advantage of your resources, and be connected, and most importantly, be prepared.
Our families need more than just extra cans of food and extra bottles of water. We need the numbers to our doctors, the prescriptions that we need, all of that you need to have with you.
Have the things in place that you need to sustain battery power for a wheelchair or a home ventilator, that you've got good history of what the day-to-day life is for this family member, so when they are being managed by a shelter or the emergency management group or the fire department, they can better be prepared to help you out in these situations. Start being proactive. Start finding out information that you can have in your home that will help us help you.
It's really good to have this in place already and have your to-go kit ready and know that you'll have what you need and you know who to contact for the rest.
So again, great advice. I share this with as many people as I can. A lot of people used to scoff at this a little bit until we had a little inland hurricane called the derecho in Iowa. Many of us were without power. Some of us for more than 2 weeks. People had problems getting out of their homes, trees down, streets blocked. And so I know we pulled out our own Go Kit here just to make sure that we were prepared and ready to go in case we lost power for more than 24 hours. It is 8:05. It is time for us to take a break. I can't believe I timed this almost perfectly. We're going to resume again in 10 minutes at 8:15. So please take 10 minutes and do what you need to do. And I will see you back here promptly at 8:15. Thank you so much. Welcome back. How are we doing? Hopefully you were able to use the facilities, maybe grab yourself a vodka to get rid of, to get you through the rest of the time with me. If you're not working, happy Friday night. As a reminder, near the end, we're going to have a Q&A with the speakers that we had last night. My friend Brittany Nichols from Kansas is monitoring the chat as our other panelists from every state are looking at what you all are putting in there. We can do some short questions with me if you have questions about my story or anything I'm saying before we go on to the larger panel. So make sure that you're using the chat or putting those questions in the Q&A. Again, I want to assure you, I've referenced a form, some forms that every state is using to help in this effort, you know, as a guide. We will get you those links. Somebody will talk about that when I'm done talking. You'll have obviously the email addresses of the people that you have close contact with in each state. I'm going to share my information at the end as well. So we will get you whatever you need, whatever you're asking for. And again, appreciate your time. I'm going to start out again with another video that I think is very appropriate. And I actually in the beginning was not going to put this in, but I believe it's a good fit for tonight with EMS. And it's another look inside the homes of families with medically fragile children. And much like you all, so much has changed since the beginning of 2020. Our lives have all taken a turn, right? In a very different direction from what we ever dreamed or thought of. And so with COVID, the layer of complexity and worriness among healthcare providers has never been higher, obviously. I will tell you, it's something that I think about every day and night, having my son in a group home, which is absolutely a vulnerable population. But we've layered this stress on as well that I think that we have to take into consideration, right? When we're treating patients and we're entering home and we're on emergency calls. And so it's a little bit longer of a clip, but I think it does a really great job giving you insight, again, to another layer, really, that you might have to peel away.
Being a parent is, of course, never a cakewalk, but parenting during a pandemic, that's an entirely new set of challenges. So many of us are having to entertain and educate our children while still trying to do our jobs at the same time. It's all one big balancing act. But the burden is especially unique for parents of children with special needs. And as Devin Dwyer reports, theirs is an inspiring story of resilience on the front lines right at home.
From outside the front door, a glimpse of life around the kitchen table in a pandemic.
Danny is medically fragile, so the virus itself would be pretty devastating to him.
Parents Megan Scully and Chris DeBott of Washington, D.C. are now full-time caregivers for their 4-year-old son, Danny, who has a rare brain disorder, putting him at increased risk of COVID-19.
One of the fights for us is keeping the front line for us here at home instead of possibly, having to go to the hospital.
As we talk outside, Danny's 2-year-old brother, Elliot, keeps that distance. His older brother, Sam, tells us he's worried.
Are you afraid of the disease?
A little, because what if Danny catches it? Or what if I catch it? If I catch it, I would probably have to stay in my room all day, maybe for 2 weeks. And I wouldn't get to see him at all for that long. And also, if I came out of my room and went into his room and I snuggled with him, he could catch COVID-19 and he could be diagnosed and could die.
It's a sobering reality affecting so many families. Rob Gorski of Ohio tells us he's overwhelmed.
I'm a dad to 3 autistic kids, and my oldest is medically fragile. So one of the things that he has right now is compromised immune system.
20-year-old son Gavin Gorski in the middle shows us his pump for gene infusions to boost his immunity.
It's pretty stressful worrying about trying to keep him healthy and safe by not exposing him to anything, really.
The Gorskis haven't left their Ohio home in 3 weeks, testing their patience with each other and communication skills. Father Rob invited us to join a family conversation.
We're sticking together. We're doing what we have to do to protect your brother. Is there any message that you guys just want to tell people about?
Always try and find ways to stay relaxed and stay calm.
Sleep. Most important one of all, sleep.
Stick with your parents. Like, we stick with our dad, and he's the best dad we could ever have. And if you see him right now, he's blushing.
It's the love and laughter that many parents say is keeping them going.
Boo.
Girlfriend.
10-year-old Mariah Winchell, who has autism and Down syndrome, gave us a tour of her quarantine life at home near Boston.
Do you want to, let's go show your schedule.
Her parents posting a daily schedule to keep learning on track.
Word of the day yesterday was bacteria.
Mom Melissa behind the camera showing us the science experiments growing yeast by the board games. The living room now home to Mariah's cardboard rocket ship and sentence diagrams.
How concerned are you that her development, her socialization is going to be set back in a big way?
I'm really concerned.
That new normal coming without many of the usual supports, those home health aides, therapists, coaches, teachers, and most of all, routines. Danny DeBott was just beginning to learn how to communicate when the pandemic closed his school.
We are homeschooling a 2nd grader, and we are trying to get Danny's therapies in to the best that we can, but we just cannot replicate what they can do at school.
And you're holding down 2 full-time jobs
That's
at
right.
the same time.
Yes.
Jeremiah, how are you dealing with this being at home?
I'm good.
You're good. Do you miss your friends?
Yeah.
Yeah. He definitely misses his friends.
Single mother Opal Foster of Southern Maryland worries about the impact of isolation on her son Jeremiah, who has Down syndrome.
There's a lot of things that they're used to in their regular routine that they're not going to be getting. We're working on kind of getting a Zoom or Skype meeting together so that you guys can see each other.
And after losing her job at a printing company last month, Foster now wonders whether they'll stay financially afloat.
We just don't know how long this is going to last. I mean, I would love to say that everything will go back to normal tomorrow and we just snap our fingers and everything will be back just the way that it was, but it won't.
So we're ending the 3-hour shift here. I'm switching off. Mariah and I wrote a story today.
Melissa Winchell, like so many parents now, toggling between daycare and her day job, a full-time university professor still lecturing, grading papers, and advising hundreds of students, among them Mariah, who's still struggling to understand the loss of normalcy.
The grief almost feels fresh to them every day, almost like they're re-experiencing it all over for the first time. So we're having a lot of, just daily crying.
How have you explained to her what a pandemic is?
I taught her the word coronavirus. She knows the word COVID-19. It's to the point now that she calls it stupid coronavirus. So, when she says, oh, why can't I see therapist so-and-so today? I say, oh, you know why? And she says, oh, stupid coronavirus.
The stress, many parents tell us, can seem unending.
The lack of adult contact is pretty challenging. I love my kids, and if I had to be on lockdown with anybody, it's my kids, so I'm glad I have them. But it does sort of take its toll.
When do you get a break?
I don't even know what that word means. I guess I don't think so much about how to get through it. I just know that my kids are relying on me, and I have to do whatever I have to do.
I am on the couch for the 2nd time since noontime today because I am just so tired.
Often exhausted, but still resilient.
I guess we're trying to make sense of this, trying to keep a positive attitude. Jeremiah is always a beacon of sunshine, as it is anyway.
It may not be pretty, and it may not be joyous, and it may not be how you want to get through something, but you'll get through it. And there is something on the other side.
Reminding all of us there's light at the end of the tunnel and in those we love.
I think this sense that nothing is permanent, that life's not a given, and that life's so fragile. That's, I think, what disabled families know. And I think that's the wisdom that we're bringing into the experience of quarantine and into COVID.
Life is so fragile indeed. Our thanks to Devin for that look at some remarkable families.
Hi, everyone. George Stephanopoulos here. Thanks for checking out the...
George, we don't need to hear from you. So on top of all of this, and I will tell you that this is something that I battled with. Again, having an emergency situation in my home, I am used to. What I'm not used to is how tired I was when Ty was still here during these last few months of the pandemic, and how sometimes I was so tired I couldn't really speak straight to family members in some cases, still trying to hold down my job, and then school is gone, and then respite is gone, and the fear really even sometimes of, do I take him into the doctor if I think he's sick? Is he really sick? I don't want to expose him, but then am I keeping him home longer, right? When I really should seek care, but I'm scared of COVID, scared of taking him out. And so, we had hunkered down, and the stress was so unbelievable. So one of the reasons why I played this clip is because some of the tools that we'll talk about may seem very elementary, and some of them may be new to people when you're going on a call, but now we have this entire other layer of this stress of people being kept into their homes. And so, as a reminder, even though what we talk about today seems like it's a simple thing, seems like it's a no-brainer thing, it's things that I invite you to do and try, just to kind of snap people back into reality with the questions that you need to ask to get to the root cause of some issues. Brittany, we're going to do a poll, and I'm going to mess with you a little bit, or whoever's doing the polls. I actually skipped the first poll because I believe that was the same poll that was done last night. So if somebody could pull up this poll for me, we're going to just ask the group, how many children in the United States have autism, and what is the incidence? Is it 1 in 19, 1 in 35, 1 in 54, or 1 in 10? And I can't vote. Panelists, the people working behind the scenes here can't vote, but I invite you all to, we'll take about 60 seconds, 90 seconds for you all to talk amongst yourselves if you're in a group, and vote what you think the incidence of children with autism in the United States is. And Brittany, I don't know if I close it in a minute and a half, or you do that. I think it's probably one of you guys.
Paul will take care of getting that closed for you.
Awesome. Thank you. Great, some pretty good guesses. I think the winner there was B, 1 in 35. If you chose C, you are the winner. The incidence is really 1 in 54. That number is growing, however. So thank you for taking that poll and being involved here with your votes. So let's talk a little bit about these kids. Autism in the spectrum is really pretty wide. The incidence, as I said, is growing. One thing that you need to know about being on the spectrum is that 1/3 of these kids can also have epilepsy. Another third can have schizophrenia. They're also known to self-injure or injure others by, biting and scratching and banging their heads. And so I think especially with this group of medically fragile children, and really probably any as they grow into adults, the care and digging into finding the real problem is probably pretty much the same. So I hope you can use the tools that we'll talk about. But let's talk about the medically fragile first, and just some considerations with certain diagnoses. I know this seems like it's really, really video heavy, but there was some really important stuff. I'm not going to play all of this one. This was actually a video that was produced to give us a look inside what it's like to be autistic and kind of what they hear when they're hypersensitive. So I'm just going to play a little bit of this video for us to give you kind of a sense of what some people with autism are experiencing.
Thank you so much for coming. We've had a really rough week. Don't worry, it's gonna be okay.
Hi, sweetie. How are you today? Today we're gonna play a game, kind of like the games that we played at school. Look what I got you. I know how much you like animals. Do you see this? This is a cat. How does a cat sound? Meow, meow. And look at this card, Lovey. This is a dog. How does a dog go? Whoop, whoop. Can you try to match these cards for me, please?
No, what dogs?
Hello? This is her. Yes? I'm really sorry. What? What do you mean she can't return? Where else are we supposed to go? Let me focus.
I don't know. It's too loud.
Stay with me. Let's look at this new set of cards.
All right, obviously, this is being a little bit dramatic, and probably more severe cases. We know there's a huge spectrum of autism, but more importantly, I wanted to play just a clip of this so we could go in and just learn about some of the sensory issues, and this is sensory issues in mass now, right, with COVID-19, and really want to talk about kids that have these hypersensitivities first that we should take in consideration. Another good thing that would be great for you to know before you came, on a call. I will tell you that with my son Ty, and personally, and I already mentioned a little bit, if we were to call 911 or if we were to call for help, one of the things that we would ask is 3 blocks before you get to our house, please turn off your lights and sirens. Please don't wear a stethoscope around your neck into our home for your own safety. If he's agitated, he will grab it and likely try to choke you. When we're in the hospital, and it's not so much an occurrence anymore, but we would have to ask people to remove their lab coats. What history has taught him through his experiences in the medical community, when he saw a lab coat, he obviously put 2 and 2 together with blood draws and pain. And so those are some of the things that we would ask just intuitively, right? If my child needed care, emergency care. Some of the other things that can help is dimming lights. Ty is sensitive to bright light, and not so much, regular lights versus fluorescent lighting, but there are some autistic children on the spectrum who have that sensitivity. And so, when you're on a call, one of the things you can ask about, especially if you need to remove a child from a home, is do they have sunglasses or a visor that we need to take with them, right? putting a towel or something over their face or eyes isn't really good enough and can agitate them more. But if they're used to sunglasses or even a visor, making sure that goes with the child. Earplugs or headphones for noisy environments, right? Even things that we don't think are noisy can be extremely noisy to a hypersensitive child. So are there earplugs? There are a lot of children who have to wear even the heavy duty headphones that you see airport workers, baggage handlers using because of the noise. If you're going into an OR with, or an ER with glass panel doors or curtains, is there a room that you need to consider that has a door on it? Making sure that it's either high walled or a closed door or an area somewhere to block so the other sensory things going on to these children can be blocked out. And that's even in the home. So many times I have a very good friend who has an autistic child who spends a lot of time in his room rocking, and that's what he likes to do. But if something were to happen and the parents had music and bright lights on out in the living room and you were called in, you know, those are some of the considerations that I would invite you to think about. You know, what bothers the child? Do we have to turn off music? Do we have to dim the lights? Things like that, just to help you when you first start doing your assessment of a child. Obviously, things that bother us all, you know, strongly scented perfumes and other products. Clothing too can also be an issue. If for some reason you need to remove clothing from one of these children or put a gown on them, that can really turn things around and not for the good. It can really set a child off. Asking for permission before touching, and I said this earlier with my son, you know, we tell physicians and healthcare providers, it's okay to examine him, just tell him what you're doing so he knows what's happening. So whether the child can express it or you have to ask the caregiver, those are all things, right, that we need to remember that may be a little bit different. As an adult, and I go in for an examination or I have an emergency, I know I need to be examined and I expect to be examined. These kids don't expect that touching. And so making sure that we're constantly either talking with the caregiver and or talking with the child in question as we move through an assessment. And then there's hyposensitivities, right? My son, we have a set of keys and they don't go to anything, but just the tactile, having him mess with the keys and shake them a little bit with a hand that moves a little bit is very comforting to him. So those sensory stimulating toys, you know, does the child have one? If we're removing a child from the home, do we have to remember to bring that with? We're strapping a child to a gurney or a cart, and they don't have that opportunity to kind of rock back and forth or swing. Those sensory stimulating activities for them can feel like the whole world is crushing them when you're taking that away. So being open and honest and asking these questions about what comforts the child, what do they need, not just what's going on medically with them, to make sure that you're treating the whole child and being as successful as you can when you're needing to do an assessment or remove them from the home. Weighted blankets. Believe it or not, my son will give you every attention and even be distracted if you're examining him if you make funny faces or talk in a funny voice, no matter what his pain level is. And so we just have to pay attention to those. The other thing I invite you, and I think maybe this was brought up last night, again, even though my child is very limited with his movements, we actually have a chart. We have a body chart. And so we can ask him where he's feeling discomfort. And if we hold it close enough to him, he can point with his one limited arm. We also have just a simple square made out of PCV pipe, and we have different pictures that we put around the square, and we will point to different body parts and ask him if it's one of those days where he's a little less mobile. And we can tell with his eyes, or he will smile when we say and point to a word that is giving him discomfort. So having those cognitive tools, either in the home or with you as EMS providers, and just talking with the care provider about the best way to determine the pain level and giving those different visual supports can be really, really crucial when you're entering a home. So other issues with not just autism, but CP and the host of other diagnoses that can come, GI problems and reflux and constipation can cause pain, and feeding issues and being hyperactive and sleep and obsessive compulsive. These are all things that we have to consider when we're assessing a child that's medically fragile. The other thing I would invite for you to know just about autism, and again with our friend's family, is Ricky. When Ricky was 13, he looked like a grown man. The kid was 6'3" at 13, and to look at him, you would think this is a full-grown man who can follow commands, and that wasn't the case at all. This was a 13-year-old kid with pretty severe autism that could be set off at any different routine change. These kids can be depressed and anxious. Some have bipolar disorder. The other thing too, God forbid, if you're ever called out to help for a search party, one thing with autism that I learned from my friend Vicky is that they're drawn to water sources, right? So rivers, ponds, swimming pools, fountains. If these kids can go missing in a blink of an eye, and the sound and flow of water brings them comfort. And so that is one thing that you can consider when you're either looking for a child that may be missing that has autism, or something simple as with our friend Ricky, they will turn on a tap and just put a bucket in the sink, and just that water, he loves hearing the water. So also on the spectrum, Asperger's is a little bit more well known. These are the kids that also have difficulty with social communication and interaction. They can be hypersensitive as well. A lot of times little to no empathy, no focus. One big thing with this group of kids, like many kids, right? Any change in routine is throwing off their whole days, can be very difficult. So an EMS call, when they're already heightened with their awareness because they're sick and they're aware enough, when EMS comes in, that change of routine can be very different. So communicating right away with the caregiver or parents to say, okay, how can we diffuse the situation to make them even more agitated? The other thing with Asperger's too are these kids are, they will take direction very literally in many cases. And I have a nephew who is on the spectrum. And one story I tell about him is they drove up from Kansas City for my son's birthday one year, and we had the spread laid out all over the kitchen, right? All over the kitchen counters. We had food for everybody. We had the birthday cake set up there ready to go. And they had come in, and Kyle was hungry. He had spent 3 hours on the road. And I took his coat off and I said, buddy, you can eat whatever you want up here. And I went to hang up the coat and come back, and he had dug into the birthday cake. We hadn't lit the candles or served anybody yet, but he took literally what I said with, you can have anything up here. So that is another good tip with kids that have Asperger's. They'll take direction very literally. Even though that social communication interaction might not be there, they can do that very, very direct and literally. Children with emotional and behavioral disorders, right? Another open communication, you'll hear me say this a million times, talk with the parents, talk with the parents, talk with the parents, right? We know that sometimes this can be genetic. Did something happen neurologically or biochemically when the child was developing? Did they have a previous injury, to their central nervous system that is causing that behavior? Maybe they had a traumatic experience. What we do know, right, is that they don't have the coping mechanisms that most of us adapt early on. I saw this a lot as a foster parent. And so when we were having medical appointments with our foster children, it was very critical for us to communicate early and often with healthcare providers in case the situation went awry with a behavior or an outburst. And then, of course, we have, just a whole host of kids across many diagnoses that just can't express themselves. And we've talked about some of these already and what you can do. These are probably the most difficult children for us to assess, right? So, I always give the example. Most kids can be in and out of a clinic within an hour, and their ear infection is found. And then when we have a medically needy child who also has an ear infection but can't tell us what hurts, can't tell us maybe what's going on, is running the fever, it can take hours in the ER to find that, or even a hospital stay sometimes. And I know that's an extreme situation, but I think you get my point. So there was this 2-year study done by the American Journal of Nursing that examined symptoms, diagnostic testing, and nursing assessment of pain in children who have profound intellectual and development issues, who are also completely dependent on caregivers or a medical device, really. So in some cases, both a caregiver and a medical device for their care. And this is really what they're suggesting, is to use cognitive tools like we talked about earlier to help assess pain, to help assess maybe a disturbance in what the child is feeling, but always, always, always eliciting the parents' and caregivers' knowledge of the child, right? So we know as parents, again, I talked about this earlier, even though Ty can't express his pain, I have ways of finding out where his pain is, and I can read his face or hear the teeth grinding when he's having pain. And so having that open communication with the parents or caregiver to see if we can both work together to pinpoint the pain and how to best treat it would be the best. Assessing pain can be hard in these kids that can't express themselves. Sometimes they can have pain and still be sleeping. Sometimes it can be a change in their mental status. Just work with the parents and use the different tools that we've already talked about to help assess that pain. But also being alert, right? So an ear infection can be very, very painful for some, not so painful for others. But we want to make sure too that we're not overlooking anything life-threatening source of pain. So again, using that parent or caregiver to say what's normal, what's not normal, and then some of the other assessment tools that we're going to look at. So Brittany, let's do another poll here quickly, if you can find this one. On average in the United States, and I think we already mentioned this, but I want to see if you're listening, what percentage of EMS runs are for pediatric patients? And we'll give you a minute and a half. And this is really funny, at least funny to me. If you can see my face on video, I've got this wall hanging behind me, and I almost feel like I look like the Virgin Mary statue with this halo going on. So I didn't plan that. This question can be a little tricky depending on where you live, if you live in a bigger city or a smaller community, but overall we're talking about in the United States, what that looks like. How are we looking, Britt? 10%, you were listening. Good. Yep, you're about right. So national average is about 10% of your runs. So let's talk about that. So the home, what can I be aware of when I'm dispatched to a home? So these are the other things, again, eliciting a lot from the caregivers and a lot from the children. So one of the things I want to know is, am I talking to the child or am I talking to the parents, or I need to involve both? As I said before, I can absolutely verbalize for my child what's going on, but when you're dealing directly with him as in an assessment, you need to talk to him and tell him exactly what you're doing. So knowing that ahead of time before you assess a child and conversing with the parent is just a mutual respect thing between you and your patient and the parent or caregiver. What can I see, right? Another great question. Not just what's going on. I know that because I've been dispatched to the house, but what else can I see? Are there those rods or other devices that are implanted for mobility? Is there an implant such as the backlift and pump? Is there other implants that are delivering medication that I can't see until I do an assessment? This is probably the most critical point that I think that I could make to any EMS provider out there. You also need to remember and ask, what is normal for this child? So when I start to take vital signs on a child with that's medically fragile, I may be taking those vitals and think, oh my God, you know, these are off the charts, or they're nowhere what they should be. This is not normal. However, it could be perfectly normal for that child, and that parent or caregiver is going to know that. We're going to know, and trust me, we're going to know what's normal for our child. So pulse is too high or too low. Breathing is shallow and not right. Temperature is too high. All of those vital signs that you're looking at, don't assume automatically on a medically fragile child that they are completely wrong. They may be normal, or they may be low, or they may be high, and the parent or caregiver can tell you that. Is there special equipment that I need to know of? You know, typically my child's communication device might not be with him in an emergency. And what does that look like? Is there a communication device or other devices that I need to bring with this child if I remove them from the home? What comforts them? I talked about the keys, right? Is there a toy? Is there even a service animal that may not be in the room when you're doing the assessment, just to keep things kind of focused on the child? What comforts the child? What do they need to go with them if we remove them from the home? What are the communication strategies that I need to know? What do they understand? What do they don't understand? How can I better assess them? And how do you want me to communicate with your medically fragile child? The other thing too is I always ask, or I encourage people to ask, is there an emergency care plan in the home? We have even gone as far with Ty's emergency care plan that is always at the front door, and now, you know, at his group home, we have made actually audio recordings of the few things that he can say and can ask for, and we put that on a flash drive in case his mother and I are not available, or someone else is not familiar with Ty, needs to understand kind of what he's expressing and saying if he is getting those words out. So we actually have that ready to go if we need to. So community connections, how can I be proactive as an EMS provider in my community to prepare for these before an emergency even happens? This picture I love, and this picture is my hero. This picture is of a school nurse. And for years, these nurses have transcended from treating the traditional bumps and bruises and scrapes to being our central force for kids like my son and other medically fragile children, so they can go to school and actually even in some cases have access to other health care. They're really our conduit for these children in EMS, right? And learning about where these kids are and who they are, especially in rural communities. This lady right here, our school nurse, she knows all of these kids. She can connect you to the families. They know of all of the children in their community, and again, can be that conduit to connect parents and families with the EMS. So I don't care how large or small your community is, what I do invite you to do in your section of town or in your community is to proactively reach out to your school nurse. And school nurses, you can do the same, right? You can proactively reach out to your EMS community and also have those conversations with your parents. I would like to connect you with a paramedic in our community or an EMS provider in our community. We'd like to just be prepared, right? In case something happens, how can we best serve you and do a pre-home visit with you and your child to see how we can serve you better when there is an emergency. And that sounds like a tall order, and I know it does, but until we have a better system in our healthcare system across the United States, such as a special healthcare registry, and to ensure everybody has a binder or a flash drive at home, this is one way, and I'm very passionate about this, if you can tell, that we can make those connections, right? School nurses can start it with families and EMS. Everybody can agree, we can share information. I know people have concerns about HIPAA, but there are ways that we can connect families and EMS providers through a school nurse. We can also have open houses, right? I mean, this is happening all across the United States. I'll show you just a quick clip on why it's important with what one EMS group did with their open house.
Lights and noises can be overwhelming for kids with autism, so today the Albion Fire Department in Lincoln hosted an open house just for them. Eyewitness News reporter Kim Kalunian spoke with first responders and families about the importance of events like this when it comes to preparing for true emergencies. She joins us from the newsroom with the story that's new tonight.
Well, the organizers of this event believe it was the first sensory-friendly safety day in the state of Rhode Island, a chance for those on the autism spectrum to get to know their first responders and vice versa.
Meet the first responders, see the trucks.
A sensory-friendly open house.
The children get a lot more comfortable, and adults get a lot more comfortable with us. They know what to expect a little better. They get to see the trucks in and out, so they're not so scared when we do arrive on scene.
Those at the Albion Fire Department in Lincoln say Saturday's event for children with autism was a learning experience for all.
It's repetitive training for these kids to get them to be aware of situations that they're going to need help with. And meeting the first responders today makes it that much easier for them.
Chuck Karboski is a retired Lincoln firefighter and works with the Autism Law Enforcement Education Coalition, or ALEC.
We train first responders on autism and other intellectual disabilities.
His 11-year-old daughter Lily is on the spectrum.
I love my dad.
She and others enjoying the open house, a touch-a-truck-like atmosphere without the lights and sirens and the stress of a real emergency.
You know, the connections that kids or individuals with special needs are making with first responders is kind of one heightened crisis and chaos. But this provides families with opportunity to have that positive connection, meet their community, and know, you know, how better to work with police, rescue, or fire.
Yes, I have autism myself. I'm happy that you're helping and spreading awareness. Feel good about that.
And the organizers of today's event say they hope to have more like this in the future and are encouraging other communities to do the same. Those at the Autism Project say they would be happy to help facilitate future events. In the newsroom, I'm Kim Kalunian, Eyewitness News.
So it's another great way, right? I talked about the school nurse being a conduit. Another great way is to have an open house. You know, touch a truck, which I just love, touch a car for police and, you know, police. It's another great way that we can do that. When you pull them in through some of these open houses, this is when you can have the talk about, do you have an emergency binder? Do you have a care plan? Tell me more about what would happen if your house had a fire, or if we had a tornado in town. Get these families to start thinking about these care plans and emergency binders that they hadn't thought of one already. One of the big fights that I take up, or I'm going to take up with the Iowa Department of Education, is I think this should be part of every IEP meeting. So, you know, every yearly and yearly meeting that our kids have in school for their individualized education plan, I think this should be a topic that's broached with parents, right? Let's get it out there and talk more about how important a Go kit is, how important these emergency binders are. Really quickly, if you don't know much about Smart 911, look it up, but it is a registry that larger cities can use. It's pretty expensive. Allen County in Ohio actually raised the funds and did their own. They've got their own through their county, where medically fragile people can go and register and put in information about themselves and about them homes to better prepare EMS in an emergency when they're dispatched to a home. Brittany, one last poll. We're getting close, friends, before we have our panel discussion. Did you hear an action item tonight that you think you can start within the next 30 days? And be honest. If it's a no, it's a no. It's helping me with my presentation. So let's do about just 60 seconds, Brittany, if we could, on this one. And I would even add, did I mention a tool that you think that you could use when assessing some of these patients? Awesome, good results. Thanks everybody for that. Couple more things before we get into our panel. This is another quote I like to say: everyone wants to be loved, heard, and respected. We all seek it and express it differently in our own way. Remember this as well, follow the definition. I talked about it earlier. I saw some comments in the chat. Glad we're already thinking about that. When we're talking with families, just make sure you're following the definition. I am on social media. I invite you to find me on Facebook, Instagram, or Twitter. My information is here for you. It was an honor to speak to you tonight. It really, truly was. I know we're winding down on time and we'll have questions, and I invite you to think about that, to go ahead and put that in chat or Q&A. We've got our friends working the chat and Q&A here. So search for me on the web if you want to connect. Here are the friends we really need to thank. All of the people listed here. Again, hopefully you already have their contact information. If you don't, somebody can get it to you when we're done. And I leave you with this, friends. Thank you so much. My name is Paul Sodders. It was an honor to talk with you. You are truly one of the reasons why I have a healthy and happy child or children right now. And one more thing, I always end with this: if 2020 hasn't changed you, you've missed the lesson. So thank you again. Brittany, I think I turn it over to you now for maybe Q&A in the panel. Yes?
Yep, absolutely. So we've already got some good questions coming in through the Q&A in the chat. So I'm going to go ahead and get started with those for you and for our panelists from last night, Melissa and Dr. Koken. And then guys, as you keep thinking of more questions, just go ahead and type those in and I'll get to them. But I've got a great one here right off the bat I want to start with for you guys. And it's kind of a long one here, so bear with me. But So the first part of it is, what is the status of national, regional, or local dialogue on issues of equity when talking about resources, funding, access, or adequate response for medically fragile children or children with special needs? So that's the first part, and I'll pause there and let you guys kind of address that before I tackle the second half.
Well, I think we're lacking there, right, in total, and I think it's a constant fight, and I think it's a worry for parents like Melissa and I, especially, being in smaller communities. How can we best serve, and how can the EMS providers get what they need to serve the people in their own communities? It's a tough conversation. I know in our group here in Iowa, we're having that conversation all of the time. We were down this really good road right before COVID hit, and then everybody gets repurposed to fight COVID. So it's a tough question, and I will tell you, and I've told Vicki this before, not representing the Iowa Department of Public Health, but on my own, working with my congressmen and my senators, not only at a local but a national level, to let them know where our needs are specifically in this arena. And just keep pushing that. And I think we need to encourage each other to do the same.
And I just kind of have one thought on that is, I think there first has to be an acknowledgement that there's a need out there, and that it's different now than it was years ago, where we have these families that are just running these mini ICUs in their living rooms, which was something that was unheard of, years ago. And so these EMS calls, I think, are going to be just more frequent. And I think if once we have that awareness and that acknowledgement, then we can actually, get the buy-in for more funding, more support, all of those things that will come with it. And I think the first is just that acknowledgement that we're sending kids home on a lot more equipment and in a lot more critical condition than we ever have before. And I think that's only going to expand.
Gotcha. All right, so I'll go ahead and move into the second part of that question. So it kind of says, EMS and public safety can be a little slow to change in some regards. So what do you kind of think of that response that we're kind of starting to re-examine that relationship with law enforcement and EMS and children in crisis? Kind of any thoughts on that as it continues to grow and change?
I think it just has to be this continuous conversation, right? And not just on that side, but with parents like ours and educating, in both arenas. It's just, it can be frustrating sometimes because sometimes you feel like you're not getting anywhere, but I really do believe it's the baby steps that grow into bigger steps. And so just continuing that conversation is very important. And, this is a great arena to do that, right? I mean, bringing in people of like minds to talk about these things and really motivate them to also take steps.
Yeah, that's exactly right. It's the communication. Part of that is also that we are bringing the family perspective to the table more often. And I think with great success. I think the feedback is really good, that people like hearing the family perspective, and actually being transparent about what we talk about and what the issues are, and then coming up with solutions from all the stakeholders that are involved. So I think we're headed in the right direction for sure.
Okay, awesome. All right, so this next one here, and I know, Paul, you kind of touched on this a little bit when you were speaking about, that connection that can be in between, EMTs, paramedics, and school nurses.
Mm-hmm.
But how would you recommend that ambulance agencies kind of help to get information on children with special needs in their area? Being conscious of HIPAA, but still trying to make sure that dispatch and everyone kind of is aware of what's going on in their community.
I think I mentioned one of them, having an open house. And advertising an open house, harder nowadays too, but it is something that you can do, in some respects virtually. And we had one virtually here in Ames, so kids could still participate. But, it's also a two-way street. I mean, I think, EMS providers and paramedics can reach out to school nurses to start having those conversations and vice versa. But that connection is really what's missing right now. So we we can connect those and do some of that preparation work and do some of those home visits in advance that I talked about. It really has to be open both ways for that to work. Right, because there are privacy concerns, but if we can encourage at least one side to start that movement and talk with parents and get parents to agree to have that open conversation with EMS providers, I really think that's the way to go. So we have that preparation ahead of time.
Yes, also in the situations where you're a small town and the special needs child is like one only child in that area, if the family could reach out to the EMS providers and get to know who's closest to them so that they're aware that perhaps they have a child who has a need for steroids when they get sick. And so they know that that child exists. And so they're ready to go ahead and pick up the child and know what's going on. I think, Melissa, you also have a lot of contact with the cardiology kids and getting them to reach out.
Yeah, my other job, my day job is working with the cardiology program at Children's Minnesota. And I was in a position, just from my own knowledge, where I was able to propose a project that, getting in touch with EMS when a child goes home. And this was something that was started by an EMS liaison. And then I've been fortunate enough to expand it beyond one specific cardiac condition. But the program is, getting a child with a severe cardiac condition that has different vitals, for example, where they have low oxygen saturations in the 80s, and that is baseline for them until they have their further surgeries. We make it a point to have a care conference where I am talking with the family about emergency preparedness. And then on the flip side, in agreement with the family, so we can avoid any HIPAA issues, is that I reach out to their local fire department EMS and give them notification of the child being discharged. And with a very simple 3 bullet points, normal oxygen, saturation is this amount, and this is what you should do. This is how much oxygen they can have. And it has been an overwhelming amount of gratitude from the EMS saying, thank you so much. This needs to be expanded. We love having this communication, or we would have never known. So my goal for 2021, if we ever can come out of this COVID kind of nightmare, is to hopefully expand that to any kid that's going home from Children's Minnesota that has a significant need that requires that communication to happen.
I love it.
Hopefully I can expand that. Yeah.
I love it.
Mm-hmm.
Well, that's amazing. Let's see this next one here. And so between Paul and Melissa, between your parental experience and then Dr. Koken, between all of your medical experience, I'd love to hear what you guys have to think on this. Have they kind of figured out yet, maybe what are some potential causes for autism? As Paul, you said it's right now 1 in 54 children roughly, with signs of that increasing. So any news on any kind of new research or studies around some potential linkages there?
Ooh, I'll leave it to the good doctor maybe to respond.
Me too.
And yeah. Melissa.
Yeah, I think it's still pretty much unknown. I think it's so multifactorial because, as you say, it's autism spectrum, and so there's numerous different results of autism on a child, and so how can you how can you narrow it down to a chromosomal abnormality or a metabolic abnormality or an intrauterine abnormality? And the one thing that we're pretty certain does not influence it, and I think people might yell and scream, but vaccines are pretty safe. And so when we get this coronavirus vaccine out, please, if the child can take it and their immune system is functional, we need to make sure we get as many people vaccinated as possible.
And just to add to that too, I'm not clinical at all, I'm not research at all, but there are so many more improved screening tools, diagnosis diagnostic tools that maybe, we were missing some that didn't have a formal diagnosis. And so, or maybe diagnosed with something else. And now that we have such great diagnostics and support with early education and birth to 3 and all of this and wonderful screening tools to get kids into some sort of therapy early on, that a formal diagnosis might be made more often than before.
Right, yeah. And the newborn screening, we talked a little bit about it last night, newborn screening for each state. It is different with each state. So you may note that some states test for 35 diseases, others test for 60 or something like that. But the newborn screen does a very good job now, and it's a lot of molecular work. And so they can really get a lot of information early on. And then as Melissa said, they can get therapy and worked into stuff right away and hopefully increase the potential of that child. And we're learning more and more ability to diagnose children with metabolic disorders every day. And those tests are also amazing. I mean, even just the tendency of a patient, how aggressive will they react to a peanut allergy? Now they can give them a scale, and they can give you a percentage on the chance of outgrowing that allergy. I mean, we never had that, 20 years ago. We just said, forever, you can't ever have peanut butter. And now they're doing the small amounts of induction of peanuts, and a lot of these kids are outliving or being less allergic to the peanut butter stuff. So it's really exciting moving forward.
Yeah, great. Thank you for sharing all of that. Next one is, I think, a great question. Pretty common situation for patient or EMS people who are on these pediatric runs. What is the best way to calm and keep both that child with healthcare needs informed during an emergency, but also keep that parent calm and informed at the same time? Managing that dual dynamic there. Can you guys kind of share your experience and advice on that?
I think for me, it's much like I said, it's asking those simple questions, even if you think they're very elementary and kind of silly to ask, to kind of snap us back. I'll tell you, before Ty had his tubes put in his ears, and he was very young, we had a pre-op physical, and we were sitting there and we were answering questions, and it for some reason did not occur to my wife or I to say, oh, he has cerebral palsy, and he had, it was just, oh, he's got this and this and other things, and it never occurred to us, and it finally snapped into our head when I can't even remember what the physician asked us, but it was like, oh my God, yeah, I mean, he has this diagnosis and we forgot to tell you. I think even especially in emergency situation, and again, especially now with COVID and just the layer of craziness that goes with that, is asking us the very simple questions, even if you think it's crazy or elementary, keeps us kind of focused. And then start that dialogue with, again, what are the comfort measures? What do I need to say to your child? Am I talking more to you or the child, or both? As I said, even though you're discussing things with me, Ty hears everything that you say. And so he would get that level of respect of you asking about how they should care for him, and is it okay to talk to him and approach him and do those things. And so for us, that's what we've had success with in the past, is don't be afraid to ask the elementary questions, because sometimes we get this into our head and just can forget to tell you things, even though when it's completely obvious with what's going on with our children.
Right. I think transparency is probably the biggest thing, is telling someone what you're going to do and trying to follow through with what you're going to do. It's always amazing to me. I'll tell them I'll come back in 5 minutes or such, and then it's a half an hour to 45 minutes when I get back in the room, and I apologize, and oftentimes the child is like looking at me like, wait, it was supposed to be only 10 minutes and what's going on? Or, it just telling them that what you're going to do, and if it changes, telling them that it changed. There's numerous times I've had, we were going to go and get an x-ray, and I get pushback from somebody, and they're saying, well, that's not quite the right test. And then I find out, oh yeah, it is not the right test. So I'll change it. And then I forget to go in the room and say, instead of getting the x-ray, we're doing an ultrasound. Oh, really? And with a child, with anybody, that's not very wonderful. But with someone who is really cued in on what's going to happen next, and what is the pattern, and how do I prepare my child for this thing, I think transparency is the utmost importance.
Yeah, I would echo that as well. And there's some kind of simple things that I know Paul alluded to in his presentation, is that tell us what you're doing, why you're doing it, so we know what's happening. So that's a lot of kids like to be either told or shown what you're going to do to them before you do it. And then kind of for the parents' perspective, the only thing that really escalates, because I'm already at an 8, I'm there. I'm already hyper focused on every single thing you're doing. And the way to get me to a 10 is that if I don't get some feedback from you that you're listening to me or that you're hearing me, because then I just kind of get louder, and because I think you're not listening or that you don't care, even though that is highly likely not at all the case. So kind of almost that teach back of, yep, I hear that you're saying that, am I right that you said that this happened and this had happened before? Is that, did I hear that correctly? It's sort of getting that, because if I think that you didn't comprehend what I say, I'm going to say it louder and I'm going to yell it, and then woo, it's gonna explode. And I think it's the same for kids. They just need to know that what's going to happen to me, what can I expect, to bring that anxiety down a little bit. And also, I know this is almost impossible with the short number of people that you have. If you just had like a point person, if you had, especially in some terrible situation where if the parent had that one person that was their contact person, that was their communication person, that this was the one that they can go to, telling them what to do. This is what's happening, especially in situations of very life-threatening and emergencies where you have someone that's just sitting, telling you like kind of a point person of, this is what's happening, this is why we're doing it, this is all that, just kind of a point person to keep that communication going.
Yeah, that makes a lot of sense. Thank you for explaining that. This next one's a little more disease specific, talking specific about children with cystic fibrosis, especially since that's something we're always learning more about, and seeing that, even as children grow into adults now, seeing them kind of with that diagnosis a bit longer. What are maybe some specific tips that you might know for these kiddos, since they're going to have usually some more complications and some more equipment needed to help manage them?
Yeah, right. So cystic fibrosis used to be a disease that was diagnosed early in life. And now we're finding that a lot of children who have had respiratory problems, perhaps diagnosed as asthma or something that they're not improving, are getting diagnosed later in life because we have a metabolic test that can test for cystic fibrosis, a genomic means of doing that. And so consequently, we're finding patients that are a lot older being diagnosed as having cystic fibrosis. And so probably the best thing to do is for those patients, once they've been diagnosed with it, is to get them hooked up with specialists in that field. They've been doing some wonderful things with different medications and different respiratory therapy type methods, and been doing, the life expectancy used to be thought that the life expectancy of a child with CF was going to be like age 20, 22. And now they're diagnosing people at the age of 20, 22 that have it, and they're living much longer lives. So getting hooked up with a specialist that maybe perhaps they see once a year, and then are seeing their regular physicians at home during the meantime. So yeah, that's, as I said, that the fact that we can do this diagnosis now and find out what's going on and then know the prognosis from that is really improving the life of a lot of these patients.
I think for me, it goes back to the key too of that prep work, right? If there's equipment in the home, knowing what that equipment is, you know, in many cases, the parents really know how to run it because it could be newer to the parents, right? And more importantly, you know, as an EMS person, as a parent, I would probably expect that you even know how to run it. And if you don't, you know, having those connections ahead of time. But I think that's where it can get so tricky, is if there's equipment that you're not familiar with, especially in smaller communities, you know, again, making that connection early and making sure that people know how to operate that equipment.
Right, and the other wonderful thing now is having the ability to take a picture and send it to somebody and showing them what it looks like. And I mean, G-tubes break off. You know, where did it break off? They're trying to describe it to you. Well, if it broke off right at the edge of the skin, that's an issue. If it broke off higher up, then you can maybe make do for a while and then get them in later. But it's just a wonderful thing to use your cell phone and send stuff to the specialist or to the ER, and they can kind of help do a little pre-diagnosis and such.
Awesome, thank you. That was good to hear. A lot of promising stuff there. Looks like we've got time for about one more. So this one, you know, we hear a lot more about caregiver fatigue in 2020, just, you know, with more people being, you know, at home with, you know, family members, especially children. But, you know, Paul and Melissa, I think you've both kind of talked on this a little bit. And, you know, when you describe your stories, and Dr. Kogan, I'm sure you have experience with this, when you see, you know, you're called to the scene and you have the child who is in crisis, but you can also see that the parents they're kind of hitting crisis mode themselves because, you know, they've been caring for this child, you know, lots of high stress situations, and you can tell they're not in a great place either. You know, kind of what are some recommendations for, you know, your first responders and nurses who might kind of come across families in that scenario?
I think for me, just recognizing that it's going to be there, right? This is a very different time, and any normal time without a pandemic, right, it could be a very stressful situation. But then again, as I said, you know, layering all of that on of you know, I don't think I maybe left the house probably for 3 months when Ty was still in my home, right? Because I can have groceries delivered. I can work from home. I didn't really need to go anywhere. And quite frankly, to me, it wasn't worth exposing myself and possibly exposing him to COVID. So I think just recognizing that as you're entering those situations, that we're in a different time, and not just for families that have a medically needy child, but really any EMS call now, right? It's all different. We have this layer of stress that people have been cooped up. As far as comfort, I go back again to the elementary things, right? Don't be afraid to ask the silly questions. Start out very elementary with your questions when you begin your assessment. In my mind, it's just the best thing that you can do. But you know, I just think just the realization that everything's a little heightened, right? I thought I was a crazy parent before, but if you would have hit me 2 months ago after I had been stuck at home with Ty for, you know, 4 months straight, Lord knows what I would have said in an emergency situation. So I think just having that awareness that it's very different for all of us now, especially, you know, families that have medically fragile children. You know, I did go through a period 5 months ago where I thought that he might be sick, and that battle with, do I take him out, right? Do I risk going to a doctor's office? How long can I wait before I see how bad it gets? Is another thing, you know, that I don't think, you know, we hold judgment against families a lot as medical health care providers, but especially now, it's a tough call to make.
Yeah, and I'll echo that for sure. And the thing, there's an easy thing that I think everyone has capability to do is in those situations, a kind, you're doing a good job. Because I think the hardest thing that families we're the hardest critics on ourselves, and we think we're failing. And it's the littlest thing that I think, probably a handful of people have done in Devin's, all of his encounters, was one of those doctors, nurses, EMTs, school nurse, anybody that just kind of goes, you're doing a really good job. Right. It means the world. And I think that's something easy that anyone can do. But then it also goes into this pre-education type thing, because for families, you might assume that they have the resources they need or they know who to contact, and they may not. So having that knowledge of what's in your community that you could offer to that family, I think what happens over time, like I didn't even know about a lot of things till Devin was 8, 9, 10 years old. And the reason why I kind of pinpointed it was that they already thought I knew. And then so they're like, oh, she must know. Or they think it's someone else's job. Well, the school should have hooked her up with that, or the hospital should have hooked her up with that. Well, really nobody did. And I didn't, and so it's like, if you know things that you can just give them resources at any moment, or even if you transported the kid to the hospital and giving a heads up to the emergency room staff, saying, do you guys have any resources? Do you guys have family services? Is there anything that can help mom? Just going that extra step. But I think the first thing is just to acknowledge the family and telling them they're doing a good job.
Right. And I always get a lot of statements from the parents. Should we have brought him in? Did I do the right thing to bring him in? Yeah. And usually I'd say, yes, you did the right thing. Yes, this is, when we're talking about that G-tube and venting, we've had a lot of kids come in with stomach pain that when we vented the G-tube, they feel much better, and they'll go, oh my gosh, why did I bring him in? I feel, I should have known how to do this. And it's like, no, you didn't. So we did it and you're doing good. Yeah. And so, yes, validating the parents' actions and giving them encouragement. And then I usually ask, especially on the newborn kids when they come in, especially when we have the multiple births kids come in, it's, what is your situation on support? Do you have people that you can call on to give you a hand? And trying to reach into their brain and ask, is there someone who will help support this family? And we do have social workers, but it's difficult. They always come in on Sundays at midnight. So, it's not going to happen that way.
It's sort of an overall blanket statement that I wanted to mention. And there could be varying opinions on this. I think we just need to do better as a whole for making emergency medicine EMS. You're part of the care team. You're not a separate outside thing that is called in. It's the involvement through the continuum of care. EMS is included in that. And that's an acknowledgement that I think is very important. I think we need to work towards that, to cross over some of these HIPAA barriers and things, because it is sort of unfortunate that we're relying on this help from somebody and they're that disconnected. And that's unfortunate. They need the EMS field, the emergency medicine field, especially for this population that is, you can anticipate will need that kind of support and help. They're part of the care team. And I think that's an acknowledgement that we have to have.
Bravo.
Thank you, Melissa. And unfortunately, that's all the time we have for the evening. But first, I want to say thank you to Paul, our speaker for tonight, and to Melissa and Dr. Koken for being our panelists. We're really appreciative of you guys sharing all of your knowledge with us. To all of our attendees, thank you so much. I'm glad you spent your Friday night learning with us. Please remember to complete those evaluations. They're going to pop up after this session, or you'll get an email tomorrow. Either one is fine. You don't need to do it twice. And then we'll be getting those certificates to you guys over the next few days. So just keep an eye out for those. Reach out to us if you have any questions, comments, ideas. We'd love to hear from you. We are here for you. But above all, take care and stay safe. Have a great weekend, guys.